Hello everyone, today we'll be talking about pneumonia. So under pneumonia we'll be discussing the definition, the types, risk factors, clinical features, investigations, management, complications. Then we'll briefly look at hospital-acquired pneumonia and aspiration pneumonia. Then at the end there will be a self-assessment question and references. So what is pneumonia? Pneumonia is defined as inflammation of lung parenchyma. Okay. So pneumonia is usually classified by the setting in which the person has contracted their infection. So we can have community setting or community-acquired pneumonia, which is acquired by a person with no underlying immunosuppression or malignancy. Or it can be acquired in a hospital or other institution such as a nursing home. So that is hospital-acquired pneumonia. And in a patient whose immune system is compromised through either genetic defect, immunosuppressive medication, or acquired immunodeficiency such as HIV infection. So community-acquired pneumonia, several different microorganisms commonly cause community-acquired pneumonia. Infection is spread by respiratory droplets. Both the clinical presentation and the range of causative organisms, they vary with age and with the effectiveness of the host immune response and innate defense system. So we said that we can have organisms that can cause pneumonia, right? Then we can have other causes of pneumonitis, such as chemical insults, such as in the expression of vomit, radiotherapy, or allergic mechanisms. So what are the risk factors for community-acquired pneumonia? So it is age less than 16 or above 65 years old, presence of comorbidities such as HIV infection, diabetes mellitus, chronic kidney disease, malnutrition, recent viral respiratory infection. We have other respiratory conditions such as cystic fibrosis, bronchiectasis, COPD, obstructing lesion, inhaled foreign body. So lifestyle, cigarette smoking, excess alcohol, intravenous drug use, iatrogenic causes such as immunosuppressant therapy that includes prolonged corticosteroids. Clinical features of pneumonia include a cough. So the cough may be dry or productive. Hemoptysis can occur. In pneumococcal pneumonia, sputum is characteristically rust-colored. Okay, so just take note that our cough, it may be dry or productive, and hemoptysis may occur, although it's not always seen. Breathlessness. The alveoli become filled with pus and debris, impairing gas exchange. Cause crackles are often heard on auscultation due to consolidation of the lung parenchyma. Bronchial breath sounds may be heard over areas of the consolidated lung. Fever. So fever can be as high as 39.5 to 40 degrees Celsius. If stringing fevers are present, this often indicates empyema. Chest pain. So chest pain is commonly pleuritic in nature, and it's due to inflammation of the pleura, and a pleural rub may be heard early on in the illness. So there are some extrapulmonary features that we're going to discuss in the table below. And these are more common in certain infections and they are not universal. Sometimes the presence of these symptoms gives a clinical clue as to the etiology. So these are the extrapulmonary features of community-acquired pneumonia. Myalgia, arthralgia, and malaise, they are common, particularly infections caused by Legionella and Mycoplasma. Myocarditis and pericarditis are cardiac manifestations of infection, most commonly in Mycoplasma pneumonia. Headache is common in Legionella pneumonia. Meningoencephalitis and other neurological abnormalities also occur, but they are much less common. Abdominal pain, diarrhea, and vomiting are common. Hepatitis can be a feature of Legionella pneumonia. Labial herpes simplex reactivation is relatively common in pneumococcal pneumonia. Other skin rashes such as erythema multiforme and erythema nodosum are found in Mycoplasma pneumonia. Stevens-Johnson syndrome is a rare and potentially life-threatening complication of pneumonia. So these are different causes of pneumonia and their clinical features. About streptococcus pneumonia, what are you going to see? So patient will present with acute onset, often preceded by flu-like symptoms, cough, food rust, colored sputum. High fevers and pleuritic chest pain is common. Bacteremia is more common in females. Excess alcohol, dry cough, and COPD, diabetes, or HIV infection. Mycoplasma pneumonia is usually a mild disease in young patients. It occurs in cycles every 3 to 4 years, usually prominent extrapulmonary symptoms, which include headache, malaise, myalgia. Complications are common, such as hemolytic anemia, erythema, multiform hepatitis, and encephalitis. Legionella disease, usually Legionella pneumophila, but other species implicated in around 10% of cases. This causes more severe disease with need for early intensive care. It's usually acquired by inhaling water mist containing bacteria. Neurological symptoms are frequently seen along with GI involvement and deranged liver enzymes, elevated creatine kinase. This is more common in smokers, males, and in young people with no comorbidities. Staphylococcus aureus. Evidence of recent influenza is found in up to around 40 to 50% patients, increasing frequency with greater severity disease. Usually, Usually methicillin-sensitive strains, but increasing incidence of methicillin-resistant disease, which can produce Panton, Valentine, Leukocidin, PVL, and result in necrotizing, cavitating pneumonia and bilateral infiltrates. Chlamydophila pneumoniae, unclear whether this is a positive or associated organism. It generally causes mild disease, but with prolonged boredom. Then these are the other causes and the clinical features. You can go through them in your free time. So diagnosis of pneumonia basically will be discussed the diagnosis and the management. So investigations and management. So initial investigation. Diagnostic microbiological tests are not needed in mild infection, which should be treated at home with standard antibiotics. Amoxicillin or clarithromycin for those with a history of penicillin allergy. Where patients have mild disease, just X-ray is not routinely recommended unless they don't improve after 48 to 72 hours. Antibiotics can be administered orally. Severity is commonly assessed by curve 65, which we're just going to look at in the next table. That is CURB 65. Okay, this gives a guide to the likely risk of fatal outcome, but they are not mandatory, and antibiotic choice must always be tempered by clinical assessment and judgment, taking into account other factors associated with increased rates of mortality. So this is the curve 65 score, where C stands for confusion present, which is abbreviated by a mental test score of less than 8/10. Plasma urea levels, which are going to be above greater than 7 millimoles per liter. Respiratory rate above 30 breaths per minute. Systolic BP below 90 millimeters mercury, or diastolic BP less than 60 millimeters mercury, and age above 65. So each of these points is assigned 1 point. So score 0 to 1, you treat them as outpatient. If they have a score of 2, admit to hospital. And if the score is 3 plus, they often require ICU care. Mortality rates increase with increasing score. So some other markers of severe community-acquired pneumonia are chest X-ray if more than one lobe is involved, partial pressure of oxygen if it's less than 8 kilopascals, low albumin which is less than 35 grams per liter, white cell count less than 4 times 10 to the power 9 per liter or greater than 20 times 10 to the power 9 per liter, so leukopenia or leukocytosis. If you have a positive blood culture, if there's the presence of other comorbidities, and if there's absence of fever in the elderly. So investigations, this include chest X-ray, blood tests, sputum culture and gram stain, pulse oximetry, HIV testing. So chest X-ray, why is that important? So radiological abnormalities, they can lag behind clinical signs. So a normal chest X-ray presentation should be repeated after 2 to 3 days if community-acquired pneumonia is suspected clinically. And one thing I need to take note is chest X-ray appearances, they're not diagnostic of any organism, but in mycoplasma and chlamydophila infection, the schedule is often more extensive than would be expected from the clinical picture. And the blood tests, we do full blood count, urine electrolytes, biochemistry, and C-reactive protein, they're often helpful. So streptococcus pneumonia, white cell count is usually above 15 times 10 to the power 9 per liter, whereby 90% are neutrophils. Inflammatory markers are significantly elevated. ESR is above 100 millimeters per hour, and CRP above 100 milligrams per liter. And mycoplasma, white cell count is usually normal. In the presence of anemia, hemolysis should be ruled out. Direct Coombs test and measurement of cold agglutinins. Legionella, there is lymphopenia without marked leukocytosis. Hyponatremia, hypoalbuminemia, and high serum levels of liver aminotransferases. Then under sputum culture and gram stain, these are required for all patients. So streptococcus pneumoniae, you're going to see gram-positive diplococci. Staphylococcus aureus, you'll see gram-positive organisms commonly appearing in clusters like a bunch of grapes. Okay? And that culture should be done for all patients who have moderate to severe community-acquired pneumonia, ideally before antibiotics are administered. In streptococcus pneumonia infection, positive blood cultures indicate more severe disease with greater mortality. And pulse oximetry and arterial blood gas analysis, these are necessary if oxygen saturation is below 94%. So, and then you must be wondering, why are we doing HIV testing? So since pneumonia is a common initial presenting illness in patients with previously undiagnosed HIV infection, an HIV test should be offered to all patients with pneumonia, unless the patient is unable to give consent or comfort measures alone are implemented due to poor prognosis. And then here, this is an X-ray showing lobar pneumonia. I have a separate video showing chest X-ray features of pneumonia, so you can have a look at that. So what is the general management of pneumonia? So general management comprises of oxygen. So supplemental oxygen should be administered to maintain saturation below 94 and 98%. And in patients with non-COPD, oxygen saturation should be maintained between 88 and 92%. Normally with controlled oxygen via fixed percentage delivery masks. Then intravenous fluids. These are required in hypertensive patients showing any evidence of volume depletion. Antibiotics. The first dose of antibiotics should be administered within 4 hours of presentation in hospital, and treatment should not be awaited while investigations are awaited. Parenteral antibiotics should be switched to oral once the temperature has settled for a period of 24 hours, provided there is no contraindication to oral therapy. If patients fail to respond to initial treatment, microbiological advice should be sought and alternative diagnosis considered. Then antibiotic regimen can be adjusted once culture and sensitivity results are available. Thromboprophylaxis. So this is administered if patient has been admitted for more than 12 hours. What we give is subcutaneous low molecular weight heparin, unless there are contraindications. Then nutritional supplementation, this need is assessed by a dietitian, particularly in severe disease. Analgesia, so you can give simple analgesia such as paracetamol or NSAID. This helps treat the pleuritic pain, thereby reducing the risk of further complications due to restricted breathing because of pain. So this is the algorithm that we used. So this is CRB65. You might notice that the U is missing. That is because like when you do a community diagnosis, you might not readily get your urea level. So that's how we're now looking at CRB65. So if CRB65 is zero, low mortality risk, home care is not appropriate. There is no need for microbiological diagnostic test. You can administer oral amoxicillin 500 milligrams TDS or oral clarithromycin 500 milligrams BD or doxycycline 100 milligrams OD. So doxy, you can give it once a day, clarithromycin twice a day, and amoxicillin twice a day. Then if CRB65 is 1 to 2, there is increased mortality risk. So hospital referral for assessment, calculate curve 65, that is if you get CRB65 as 1 to 2, okay? Then curve 65, if it's 1, mortality is less than 3%. May be suitable for short-stay or ambulatory care. No microbiological diagnostic tests are necessary unless outbreak is suspected or mycoplasma epidemic. So you give oral amoxicillin 500 milligrams 3 times daily or oral clarithromycin 500 milligrams twice daily or doxycycline 100 milligrams daily. 200 milligrams initial loading dose if penicillin allergic. Curve 65, if they get a score of 2, the mortality rate is 9%. Blood cultures, sputum if no antibiotics, pneumococcal antigen if suspected clinically, and do a culture if positive. Serology or PCR if there is an epidemic. Curve 65 2. You can give amoxicillin 500 to 1000 milligrams 3 times daily plus clarithromycin 500 milligrams twice daily orally, or you give IV if orally is not possible. If there is penicillin allergy, you can give doxycycline 100 milligrams daily, or levofloxacin 500 milligrams 2 times daily, or moxifloxacin 400 milligrams daily orally. Then CRB65, if the score is 3 to 4, that is high mortality risk and urgent referral to hospital for assessment and admission. So curve 65, if the score is between 3 to 5, 15 to 40% mortality, do a blood culture, sputum, pneumococcal antigen, Legionella antigen, serology, and viral PCR. Curve 65, 4 to 5, refer to senior clinician and ITU for urgent assessment. Curve 65, 3 to 5, we give antibiotics as soon as possible. We give amoxicillin 1.2 grams 3 times daily intravenously plus clarithromycin 500 milligrams twice daily IV. Then you can give fluoroquinolones if Legionella disease is suspected. Alternative treatment is penicillin. If there is penicillin allergy, can give IV cephalosporin, ceftriaxone 2 grams daily plus clarithromycin 500 milligrams twice daily, or benzyl penicillin 1.2 grams 4 times daily or 4 hourly plus a fluoroquinolone, which can be levofloxacin or moxifloxacin. So complications of pneumonia. General complications include respiratory failure, sepsis. Local complications include pleural effusion, empyema, lung abscess, organizing pneumonia. If you'd like to, so I'm not going to talk about this in much detail, however, if you'd like to, request in the comments, I'll make another video on complications. So hospital-acquired pneumonia, this is defined as new onset of cough with purulent sputum along with a compatible X-ray demonstrating consolidation in patients who are beyond 2 days of their initial admission to hospital or who have been in a healthcare setting within the last 3 months. Healthcare settings include nursing or residential homes as well as acute care facilities such as hospitals. So please take note in patients who are beyond 2 days of the initial admission, okay? Aspiration pneumonia, acute aspiration of gastric contents into the lungs can produce an extremely severe and sometimes fatal illness owing to the intense destructiveness of gastric acid. This can complicate anesthesia, particularly during pregnancy, which is referred to as Mendelssohn's syndrome. Because of the bronchial anatomy, the most usual site for aspirated material to end up at the right middle lobe and apical or posterior segments of the right lower lobe. Okay. The persistent pneumonia is often due to anaerobe and progresses to lung abscess or even bronchiectasis if protracted. So this is the question for you. Thank you for watching.